buprenex, can produce some pain relief but bind tightly to mu receptors and can block the effect of other drugs. Agonist antagonists and partial agonists currently have limited clinical application in pain management. Dual mechanism agents. Some analgesics have two distinct actions or dual mechanisms. Tramadol, or Ultram, is a weak mu agonist and inhibits the reuptake of norepinephrine and serotonin. It is effective in low back pain, osteoarthritis, fibromyalgia, diabetic peripheral neuropathic pain, polyneuropathy, and post-herpetic neuralgia. The most common side effects are like those of other opioids, including nausea, constipation, dizziness, and sedation. As with other medications that increase serotonin and norepinephrine, avoid this drug in patients with a history of seizures because it lowers seizure threshold. Tapentadol, or Naquinta, is a centrally acting analgesic that works at mu receptors and inhibits norepinephrine reuptake. It is approved for management of moderate to severe acute pain. For chronic moderate to severe pain, an extended release formula is available. The side effects are like those of conventional opioids, except that this drug is associated with less nausea and constipation. Opioids to avoid. Some opioids should be avoided for pain relief because of limited efficacy and/or toxicities. Meperidine or Demerol or pethidine is associated with neurotoxicity, e.g. seizures, caused by accumulation of its metabolite, normeperidine. Its use is limited for very short-term, i.e. less than 48 hours, treatment of acute pain when other opioid agonists are contraindicated. Side effects of opioids. Common side effects of opioids include constipation, nausea and vomiting, sedation, respiratory depression, and pruritus. With continued use, many side effects diminish. The exception is constipation. Less common side effects include urinary retention, myoclonus, dizziness, confusion, and hallucinations. Constipation is the most common side effect of opioids. Left untreated, it may increase a person's pain and can lead to fecal impaction and paralytic ileus. Because tolerance to opioid-induced constipation does not develop, a bowel regimen should be started at the beginning of the opioid therapy and continued for as long as the person takes opioids. Although dietary fiber, fluids, and exercise should be encouraged, these measures alone may not be enough. Most patients should use a gentle stimulant laxative, e.g. senna, plus a stool softener, e.g. docusate sodium. Other agents, e.g. milk of magnesia, bisacodyl, polyethylene glycol, lactulose, can be added if needed. Methyl naltrexone, Relistor, naldemidine, or Simproic, and naloxegol, or Movantik, are peripheral opioid receptor antagonists used for opioid-induced constipation when the response to traditional laxative and stool softener therapy is insufficient. Nausea is often a problem in opioid-naive patients. The use of an antiemetic, such as ondansetron or Zofran, metoclopramide or Reglan, transdermal scopolamine, or hydroxyzine, Vistaril, can prevent or minimize nausea and vomiting until tolerance develops, usually within 1 week. Opioids delay gastric emptying, patient relates gastric fullness. Metoclopramide can reduce this effect. If nausea and vomiting are severe and persistent, changing to a different opioid may be needed. Sedation is usually seen in opioid-naive patients being treated for acute pain. Regularly monitor patients receiving opioid analgesics for acute pain, especially in the first few days, e.g. after surgery. Be aware that the risk for unintended sedation in post-operative patients is greatest within 4 hours after leaving the post-anesthesia care unit. Opioid-induced sedation resolves with the development of tolerance. Persistent sedation with chronic opioid use can be effectively treated with psychostimulants such as caffeine, dextroamphetamine, dexedrine, methylphenidate, Ritalin, or the anti-cataleptic drug modafinil, Provigil. The risk for respiratory depression is higher in opioid-naive, hospitalized patients who are treated for acute pain. Clinically significant respiratory depression is rare in opioid-tolerant patients, and when opioids are titrated to analgesic effect. Patients most at risk for respiratory depression include those who are 65 or older, have a history of snoring or witnessed apneic episodes, report excessive daytime sleepiness, have underlying heart or lung disease, are obese, body mass index greater than 30 kilograms per meter squared, have a history of smoking, more than 20 pack years, or are receiving other CNS depressants, e.g. sedatives, benzodiazepines, antihistamines. For postoperative patients, the greatest risk for opioid-related respiratory adverse events is within the first 24 hours after surgery. Clinically significant respiratory depression cannot occur in patients who are fully awake. Frequently monitor both the sedation level and respiratory rate in patients receiving opioid analgesics. A sedation scale can be used for monitoring and providing appropriate interventions based on the level of sedation. Table 8.10. Safety alert. Sedation and respiratory depression. If the patient's respiratory rate falls below 8 or 10 breaths per minute and the sedation level is 3 or greater, you should vigorously stimulate the patient and try to keep the patient awake. If the patient becomes oversedated, apply oxygen. In this situation, the opioid dose should be reduced. For patients who are excessively sedated or unresponsive, we can give naloxone, an opioid antagonist that rapidly reverses the effects of opioids. Naloxone can be given IV, subcutaneously, or intranasally. Evzio, handheld autoinjector containing naloxone, can be used by a caregiver or a family member to treat a person known or suspected to have an opioid overdose. If the patient has been taking opioids regularly for more than a few days, use naloxone carefully because it can precipitate severe, agonizing pain, profound withdrawal symptoms, hypertension, and pulmonary edema. Because naloxone's half-life is shorter than that of most opioids, frequently monitor the patient. Pruritus, or itching, is another common side effect of opioids. It occurs most often when opioids are given by neuraxial, i.e. epidural, intrathecal routes. What is the intrathecal route, you may be asking? Intrathecal administration is a route of administration for drugs via an injection into the spinal canal or into the subarachnoid space so that it reaches the cerebrospinal fluid and is useful in spinal anesthesia, chemotherapy, or pain management applications. That's from Wikipedia. Managing opioid-induced pruritus in non-cancer patients may include low-dose infusions of naloxone. A rare but concerning problem with long-term and even short-term use of high-dose opioids is opioid-induced hyperalgesia, OIH. OIH is a state of nociceptive sensitization caused by exposure to opioids. It is characterized by a paradoxical response in which patients become more sensitive to certain painful stimuli and report increased pain with opioid use. The exact mechanism is not clearly understood, but it may be due to neuroplasticity changes. This may explain why opioids tend to lose their effectiveness in certain patients over time. Adjuvant analgesic therapy. Analgesic adjuvants are drugs that can be used alone or in conjunction with opioid and non-opioid analgesics. Table 8.11. Generally, these agents were developed for other purposes, e.g. anti-seizure drugs, antidepressants, and found to be effective for treating pain. Alpha-2 adrenergic agonists. We think clonidine and tizanidine, Xanaflex, the most widely used alpha-2 adrenergic agonists, work on the central inhibitory alpha-adrenergic receptors. These agents may also decrease norepinephrine release peripherally. They are given for chronic headache and neuropathic pain. Antidepressants. Tricyclic antidepressants, TCAs, enhance the descending inhibitory system by preventing the cellular reuptake of serotonin and norepinephrine. Higher levels of serotonin and norepinephrine in the synapse inhibit the transmission of nociceptive signals in the CNS. Other potential beneficial actions of TCAs include sodium channel modulation, alpha-1 adrenergic antagonist effects, and a weak NMDA receptor modulation. They are effective for a variety of pain syndromes, especially neuropathic pain syndromes. However, side effects such as sedation, dry mouth, blurred vision, and weight gain limit their usefulness. Antidepressants that selectively inhibit reuptake of serotonin and norepinephrine, SNRIs, are effective for many neuropathic pain syndromes and have fewer side effects than TCAs. These agents include venlafaxine, desvenlafaxine, Pristiq, milnacipran, Savella, and bupropion. Anti-seizure drugs. Anti-seizure drugs affect peripheral nerves and the CNS in several ways, including sodium channel modulation, central calcium channel modulation, and changes in excitatory amino acids and other receptors. Agents such as gabapentin, lamotrigine, and pregabalin are valuable adjuvant agents in chronic pain therapy and are being used more in the treatment of acute pain. GABA receptor agonist. Baclofen, an agonist at GABA receptors, can interfere with the transmission of nociceptive impulses. It is used for muscle spasms and neuropathic pain. It crosses the blood-brain barrier and is much more effective for spasticity when delivered intrathecally. Corticosteroids include dexamethasone, prednisone, and methylprednisolone, Medrol. They are used for managing acute and chronic cancer pain, pain secondary to spinal cord compression, and inflammatory joint pain syndromes. Mechanisms of action may be related to the ability of corticosteroids to decrease edema and inflammation. Corticosteroids have many side effects, especially when given chronically in high doses. These include hyperglycemia, fluid retention, dyspepsia and GI bleeding, impaired healing, muscle wasting, osteoporosis, adrenal suppression, and susceptibility to infection. Because they act through the same final pathway as NSAIDs, do not give corticosteroids at the same time as NSAIDs. Local anesthetics. For acute pain from surgery or trauma, Local anesthetics, such as bupivacaine and ropivacaine, can be given epidurally by continuous infusion or by intermittent or continuous infusion with regional nerve blocks. Systemic lidocaine, given in an IV infusion, is sometimes used for neuropathic and postoperative visceral pain. Topical applications are used to interrupt transmission of pain signals to the brain. For example, 5% lidocaine patch, Lidoderm, is a first-line agent for the treatment of several types of neuropathic pain. In the treatment of chronic severe neuropathic pain that is refractory to other analgesics, oral therapy with mexiletine, Mexitil, may be tried. Cannabinoids. Cannabinoid-derived medications show promise in the treatment of neuropathic pain, certain pain syndromes, and some symptoms. However, these preparations have sparked considerable controversy and confusion, mostly because cannabinoids are related to the cannabis plant, also known as marijuana. Synthetic cannabinoids, e.g. dronabinol or Marinol, have been approved for medical use. Smoking marijuana or cannabis rapidly increases plasma levels of tetrahydrocannabinol, THC. The increase depends on composition of the marijuana cigarette and inhalation technique. As a result, this form of use is associated with variable pain relief. With commercially available oral preparations, the absorption and bioavailability are more reliable and predictable. Cannabinoids exert their analgesic effect primarily through the cannabinoid 1, CB1, and CB2 receptors. Activation of cannabinoid receptors modulates neurotransmission in the serotonergic, dopaminergic, and glutaminergic systems, as well as other systems. Cannabinoids also enhance the endogenous opioid system. Other beneficial effects include alleviating nausea and increasing appetite. They may have opioid-sparing effects, possibly reducing opioid tolerance and symptoms of opioid withdrawal. Administration. Scheduling. Appropriate analgesic scheduling focuses on preventing or controlling pain, rather than providing analgesics only after the patient's pain has become severe. Pre-medicate a patient before procedures and activities that will likely produce pain. Similarly, a patient with constant pain should receive analgesics around the clock, rather than on an as-needed basis. These strategies control pain before it starts and usually result in lower analgesic requirements. Use fast-acting drugs for incident or breakthrough pain, while long-acting analgesics are more effective for constant pain. Examples of fast-acting and sustained-release analgesics are described later in this section. Titration. Analgesic titration is dose adjustment based on assessment of the adequacy of analgesic effect versus the side effects produced. The amount of analgesic needed to manage pain varies widely, and titration is an important strategy in addressing this variability. An analgesic can be titrated upward or downward, depending on the situation. For example, in a postoperative patient, the dose of analgesic decreases over time as the acute pain resolves. On the other hand, opioids for chronic severe cancer pain may be titrated upward many times over the course of therapy to maintain adequate pain control. The goal of titration is to use the smallest dose of analgesic that provides effective pain control with the fewest side effects. Equinalgesic dosing. The term equinalgesic dose refers to a dose of one analgesic that is equivalent in pain-relieving effects to a given dose of another analgesic. Table 8.12. This equivalence helps guide opioid dosing when changing routes or opioids when a specific drug is ineffective or causes intolerable side effects. Equinalgesic charts and conversion programs are widely available in clinical guidelines, in healthcare facility pain protocols, and on the internet. They are useful tools, but you need to understand their limitations since these doses are estimates. To ensure safety, all changes in opioid therapy must be carefully monitored and adjusted for the individual patient. Administration routes. We can deliver opioids and other analgesic agents by many routes. This flexibility allows the HCP to 1. Target a particular anatomic source of the pain, 2. Achieve therapeutic blood levels rapidly when necessary, 3. Avoid certain side effects through localized administration, and 4. Provide analgesia when patients are unable to swallow. The following discussion highlights the use and nursing considerations for analgesic events delivered through a variety of routes. Oral. Generally, oral administration is the route of choice for the person with a functioning GI system. Most pain medications are available in oral preparations, such as liquid and tablet. For opioids, larger oral doses are needed to achieve the equivalent analgesia of doses given IM or IV. Table 8.12. For example, 10 milligrams of parenteral morphine is equivalent to around 30 milligrams of oral morphine. The reason larger doses are needed is related to the first-pass effect of hepatic metabolism. This means that oral opioids are absorbed from the GI tract into the portal circulation and shunted to the liver. Partial metabolism in the liver occurs before the drug enters the systemic circulation and becomes available to peripheral receptors and can cross the blood-brain barrier and access CNS opioid receptors, which is needed to produce analgesia. Oral opioids are as effective as parenteral opioids if the dose is large enough to compensate for the first-pass metabolism. Many opioids are available in short-acting, immediate release, and long-acting, sustained release or extended release, oral preparations. Immediate release products are effective in providing rapid, short-term pain relief. Sustained release or extended release preparations generally are given every 8 to 12 hours, although some preparations, e.g. Cadian, Exalgo, may be dosed every 24 hours. Safety alert. Sustained release or extended release preparations. These should not be crushed, broken, dissolved, or chewed. These drugs are to be swallowed whole. If all the medicine is released into a person at once, serious side effects can occur, including death from overdose. Transmucosal and buccal routes. Although morphine has historically been given sublingually to people with cancer pain who have difficulty swallowing, little of the drug is absorbed from the sublingual tissue. Instead, most of the drug dissolves in saliva and is swallowed, making its absorption similar to that of oral morphine. Several transmucosal fentanyl products are used for the treatment of breakthrough pain. These include 1. Oral transmucosal fentanyl citrate, OTFC, or Acute, with the fentanyl embedded in a flavored lozenge on a stick that is absorbed by the buccal mucosa after being rubbed actively over it when given as the lozenge, not sucked as a lollipop. 2. Fentanyl buccal tablet, FBT, Fentora, in the form of a buccal tablet that disintegrates. And 3. Fentanyl sublingual, Abstral. Transmucosal absorption allows the drug to enter the bloodstream and travel directly to the CNS. Pain relief typically occurs 5 to 7 minutes after administration. These formulations should be used only for patients who are already receiving and are tolerant to opioid therapy. Intranasal route. Intranasal administration allows delivery of medication to highly vascular mucosa and avoids the first-pass effect. Butorphanol is given for acute headache and other intense, recurrent types of pain. A transmucosal fentanyl nasal spray, Lazanda, is available for the treatment of breakthrough pain. Rectal. The rectal route is often overlooked but is particularly useful when the patient cannot take an analgesic by mouth, such as with severe nausea and vomiting. Analgesics that are available as rectal suppository include hydromorphone, oxymorphone, morphine, and acetaminophen. If rectal preparations are not available, Many oral formulations can be given rectally if the patient is unable to take medications by mouth. Transdermal route. Transdermal patches are designed for systemic drug delivery, e.g. Duragesic, or for topical or local delivery, e.g. Lidoderm. Fentanyl, Duragesic, is useful for the patient who cannot tolerate oral analgesic drugs. Absorption from the patch is slow. It takes 12 to 17 hours to reach full effect with the first application. Therefore, transdermal fentanyl is not suitable for rapid dose titration, but can be effective if the patient's pain is stable and the dose needed to control it is known. Patches may have to be changed every 48 hours rather than the recommended 72 hours based on individual patient responses. Patches are applied to intact, non-hairy skin. Rashes caused by the patch's adhesive may be reduced by preparing the skin 1 hour before placement with a weak corticosteroid cream. Bio-occlusive dressings are available if the patch keeps falling off because of sweating. A transdermal patient-controlled analgesia, PCA system, ionitophoretic transdermal system, ITS, is available. A 5% lidocaine impregnated transdermal patch, Lidoderm patch, is used for post-herpetic neuralgia. The patch is placed directly on the intact non-hairy skin in the area of post-herpetic pain and left in place for up to 12 hours. There are few systemic side effects, even with chronic use. Creams and lotions containing 10% trolamine salicylate, Aspercream, Mioflex cream, are available for joint and muscle pain. This aspirin-like substance is absorbed locally. This route avoids GI irritation, but not the other side effects of high-dose salicylates. Topical diclofenac solution and a diclofenac patch, Flector, are effective for osteoarthritic pain of the knee. Other topical analgesic agents, such as capsaicin, e.g. Zostrix, and lidocaine, LMX cream, also provide analgesia. Derived from red chili pepper, capsaicin acts on C-fiber heat receptors. If used 3 or 4 times a day for 4 to 6 weeks, it will cause the C nociceptor fibers to become inactive. The result is neuronal resistance to painful stimuli. Capsaicin may control pain associated with diabetic neuropathy, arthritis, and post-herpetic neuralgia. LMX cream is useful for control of pain associated with venipunctures. Cover the targeted area of intact skin with a layer of LMX for at least 20 to 30 minutes, then wipe it off prior to beginning a painful procedure. Parenteral routes. The parenteral routes include IV and subcutaneous administration. Single, repeated, or continuous dosing, IV or subcutaneous, is possible with parenteral routes. IV administration is the best route when immediate analgesia and rapid titration are needed. Continuous IV infusions provide excellent steady-state analgesia through stable blood levels. Onset of analgesia after subcutaneous administration is slow, and thus the subcutaneous route is rarely used for acute pain management. However, continuous subcutaneous infusions are effective for pain management at the end of life. This route is especially helpful for people with abnormal GI function and limited venous access. The IM route is not recommended because injections cause significant pain and result in unreliable absorption. With chronic use, IM injections can result in abscesses and fibrosis. Intraspinal delivery. Intraspinal or neuraxial opioid therapy involves inserting a catheter into the subarachnoid space, intrathecal delivery, or the epidural space, epidural delivery. Figure 8.6. Analgesics are injected either by intermittent bolus doses or continuous infusion. Percutaneously placed temporary catheters are used for short-term therapy, 2 to 4 days, and surgically implanted catheters are used for long-term therapy. Although the lumbar region is the most common site of placement, epidural catheters may be placed at any point along the spinal column, cervical, thoracic, lumbar, or caudal. The tip of the epidural catheter is placed as close to the nerve supplying the painful dermatome as possible. For example, a thoracic catheter is placed for upper abdominal surgery, and a high lumbar catheter is used for lower abdominal surgery. Fluoroscopy ensures correct placement of the catheter. Intraspinal analgesics are highly potent because they are delivered close to the receptors in the spinal cord dorsal horn. Smaller doses of analgesics are needed than with other routes, including IV. For example, 1 milligram of intrathecal morphine equals 10 milligrams of epidural morphine, 100 milligrams of IV morphine, and 300 milligrams of oral morphine. Drugs delivered intraspinally include morphine, fentanyl, sufentanil, sufenta, alfentanil, alfenta, hydromorphone, clonidine, and ziconotide, a calcium channel receptor modulator for use in neuropathic pain syndromes. Nausea, itching, and urinary retention are common side effects of intraspinal opioids. Complications of intraspinal analgesia include catheter displacement and migration, accidental infusions of neurotoxic agents, epidural hematomas, and infection. Clinical manifestations of catheter displacement or migration depend on catheter location and the drug being infused. A catheter that migrates out of the intrathecal or epidural space causes a decrease in pain relief with no improvement with more boluses or increases in the infusion rate. If an epidural catheter migrates into the subarachnoid space, increased side effects become quickly apparent. Somnolence, confusion, and increased anesthesia, if the infusate contains an anesthetic, occur. Check with institutional policy before aspirating cerebrospinal fluid to determine intrathecal catheter placement. Migration of a catheter into a blood vessel may cause an increase in side effects because of systemic drug distribution. Many drugs and chemicals are highly neurotoxic when given intraspinally. These include antibiotics, chemotherapy agents, potassium, parenteral nutrition, and many preservatives, such as alcohol and phenol. To avoid inadvertent injection of IV drugs into an intraspinal catheter, the catheter should be clearly marked as an intraspinal access device. Only preservative-free drugs should be used. Infection is a rare but serious complication of intraspinal analgesia. Assess the skin around the exit site for inflammation, drainage, or pain. Manifestations of an intraspinal infection include diffuse back pain, pain or paresthesia during bolus injection, and unexplained sensory or motor deficits in the lower limbs. Fever may or may not be present. Acute bacterial infection, meningitis, is manifested by photophobia, neck stiffness, fever, headache, and altered mental status. Regular, meticulous wound care and using sterile technique when caring for the catheter and injecting drugs reduces infection risk. Long-term epidural catheters may be placed for terminal cancer patients or patients with certain pain syndromes that are unresponsive to other treatments. If a long-term indwelling epidural catheter is used, bacterial filters are recommended. Implantable pumps. Intraspinal catheters can be surgically implanted for long-term pain relief. The surgical placement of an intrathecal catheter to a subcutaneously placed pump and reservoir allow for the delivery of drugs directly into the intrathecal space. The pump, which is normally placed in a pocket made in the subcutaneous tissue of the abdomen, may be programmable or fixed. We make changes reprogramming the pump, changing the mixture or concentration of drug in the reservoir. The pump is refilled every 30 to 90 days, depending on flow rate, mixture, and reservoir size. Patient-controlled analgesia. PCA, or demand analgesia, is a method that allows the patient to self-administer preset doses of an analgesic within a prescribed time period by activating an infusion pump. Routes of administration include oral, IV, epidural, inhaled, nasal, and transcutaneous. In acute care, PCA often refers to an electronically controlled infusion pump that delivers the medication by an IV or epidural route. Patient-controlled epidural analgesia, PCEA. PCEA often combines an opioid and local anesthetic. PCA also can be adopted for oral administration. With PCA/PCEA, a dose of opioid is delivered when the patient decides a dose is needed. PCA/PCEA uses an infusion system in which the patient pushes a button to receive a bolus infusion of an analgesic. PCA/PCEA is used widely for the management of acute pain, including postoperative pain and cancer pain. Opioids, such as morphine and hydromorphone, are often given via PCA therapy for acute and chronic pain. Sometimes IV PCA is given with a continuous or background infusion called a basal rate, depending on the patient's opioid requirement. Adding a basal rate in opioid-naive patients and those at risk for adverse respiratory outcomes, e.g. older age, obstructive sleep apnea, lung disease, may lead to serious respiratory events. Basal rates are often used with epidural catheter pain management. Because the medication is delivered directly into the epidural space, the amount of opioid is 10 times likely than is needed by IV route. This lessens the risk for respiratory depression, but does not eliminate it. Patient teaching is very important with the use of PCA/PCEA. Help the patient understand the mechanics of getting a drug dose and how to titrate the drug to achieve good pain relief. Teach the patient to self-administer the analgesic before pain is severe. Assure the patient that he or she cannot overdose because the pump is programmed to deliver a maximum number of doses per hour. The patient will not receive more analgesic once the maximum dose has been reached. If the maximum dose is inadequate to relieve pain, the pump can be reprogrammed to increase the amount or frequency of dosing. In addition, you can give bolus doses if they are part of the HCP's orders. To make a smooth transition from infusion PCA to oral drugs, the patient should receive increasing doses of oral drug as the PCA analgesic is tapered. Patient-controlled delivery systems are intended for use by the patient. An authorized agent-controlled analgesia, AACA, is a method of delivery performed by a consistently available and competent person for patients who are unable to independently activate PCA devices. This authorized agent must be carefully selected, taught the principles of PCA, and capable of recognizing pain and the appropriate times to give medication via the PCA device. Understand your institution's policies about PCA and AACA. Interventional therapy. Therapeutic nerve blocks. Nerve blocks involve one-time or continuous infusion of local anesthetics into a particular area to produce pain relief. These techniques are also called regional anesthesia. Nerve blocks interrupt all afferent and efferent transmission to the area and thus are not specific to nociceptive pathways. They include local infiltration of anesthetics into a surgical area, e.g. chest incisions, inguinal hernia, and injection of anesthetic into a specific nerve, e.g. occipital pudendal nerve, or nerve plexus, e.g. brachial or celiac plexus. Nerve blocks can be used during and after surgery to manage pain. For longer-term relief of chronic pain syndromes, local anesthetics can be given by a continuous infusion. Adverse effects of nerve blocks are similar to those for local anesthetics delivered by other systemic routes. Effects include systemic toxicity, resulting in dysrhythmias, confusion, nausea and vomiting, blurred vision, tinnitus, and metallic taste. Temporary nerve blocks affect motor function and sensation and typically last 2 to 24 hours, depending on the agent and the site of injection. Motor ability generally returns before sensation. Neuroablative techniques. Neuroablative interventions are done for severe pain that is unresponsive to all other therapies. They involve destroying nerves, thereby interrupting pain transmission. Destruction is by surgical resection or thermocoagulation, including radiofrequency coagulation. Neuroablative interventions that destroy the sensory division of a peripheral or spinal nerve are classified as neurectomies, rhizotomies, and sympathectomies. Neurosurgical procedures that ablate the lateral spinothalamic tract are classified as chordotomies if the tract is interrupted in the spinal cord, or tracheotomies if the interruption is in the medulla or midbrain of the brainstem. Figure 8.7. Chordotomy and tracheotomy can be done with the aid of local anesthesia by a percutaneous technique under fluoroscopy. Neuroaugmentation involves electrical stimulation of the brain and spinal cord. Spinal cord stimulation, SCS, is done much more often than brain stimulation. The most common use of SCS is for chronic back pain secondary to nerve damage that is unresponsive to other therapies. Other use include CRPS, spinal cord injury pain, and interstitial cystitis. Potential complications include those related to the surgery, bleeding and infection, migration of the generator, which usually is implanted in the subcutaneous tissues of the upper gluteal or pectoralis area, and nerve damage. Non-drug therapies for pain. Non-drug strategies play an important role in pain management, Table 8.13. They can reduce the dose of an analgesic needed to relieve pain and thereby minimize side effects of drug therapy. Moreover, they increase the patient's sense of personal control about managing pain and increase coping skills. Some strategies are thought to alter ascending nociceptive input or stimulate descending pain modulation mechanisms. These non-drug therapies are useful for both acute and chronic pain. Physical pain relief strategies. Massage. Massage is useful for acute and chronic pain. Many different massage techniques exist, including moving the hands or fingers over the skin slowly or briskly with long strokes or in circles, superficial massage, or applying firm pressure to the skin to maintain contact while massaging the underlying tissues, deep massage. Another type is trigger point massage. A trigger point is a circumscribed hypersensitive area within a tight band of muscle. It is caused by acute or chronic muscle strain. It feels like a tight knot under the skin. Trigger point massage is done by applying strong, sustained digital pressure, deep massage, or a gentler massage with ice, followed by muscle heating. Massage is discussed in Chapter 6. Exercise is an essential part of the treatment plan for patients with chronic pain, particularly those with musculoskeletal pain. Many patients become physically deconditioned from their pain, which in turn leads to more pain. Exercise acts via many mechanisms to relieve pain. It enhances circulation and cardiovascular fitness, reduces edema, increases muscle strength and flexibility, and enhances physical and psychosocial functioning. Tailor an exercise program to the patient's physical needs and lifestyle. It may include aerobic exercise, stretching, and strengthening exercises. Trained personnel, e.g. physical therapists, should supervise the program. Transcutaneous electrical nerve stimulation. TENS involves the delivery of an electric current through electrodes applied to the skin surface over the painful region, at trigger points, or over a peripheral nerve. A TENS system consists of 2 or more electrodes connected by lead wires to a small battery-operated stimulator, figure 8.8. Usually a physical therapist is responsible for delivering TENS therapy, although nurses can be trained in the technique. TENS may be used for acute pain, including postoperative pain, and pain associated with physical trauma. The effects of TENS on chronic pain are less clear, but it may be effective in these cases. Acupuncture. Acupuncture is a technique of traditional Chinese medicine in which very thin needles are inserted into the body at designated points. Acupuncture is used for many kinds of pain. Acupuncture is described in Chapter 6. Heat therapy. Heat therapy is the application of either moist or dry heat to the skin. Heat therapy can be either superficial or deep. You can apply a superficial heat using an electric heating pad, dry or moist, a hot pack, hot moist compresses, warm wax, paraffin, or a hot water bottle. To expose large areas of the body, patients can immerse themselves in a hot bath, shower, or whirlpool. Physical therapy departments provide deep heat therapy through techniques such as short-wave diathermy, microwave diathermy, and ultrasound therapy. Patient and caregiver teaching about heat therapy is described in Table 8.14. Cold therapy. Cold therapy involves the application of either moist or dry cold to the skin. Dry cold can be applied by using an ice bag, moist cold by using towels soaked in ice water, cold hydrocollator packs, or immersion in a bath or under running cold water. Icing with ice cubes or blocks of ice made to resemble popsicles is another technique used for pain relief. Cold therapy is thought to be more effective than heat for a variety of painful conditions, including acute pain from trauma or surgery, acute flare-ups of arthritis, muscle spasms, and headache. Patient and caregiver teaching about cold therapy is described in Table 8.14. Cognitive Therapies. Techniques to alter the affective, cognitive, and behavioral components of pain include a variety of cognitive strategies and behavioral approaches. For example, patients can identify and challenge negative pain-related thoughts and replace them with more positive coping thoughts. Some techniques need little training and often are adopted independently by the patient. For others, a trained therapist is needed. Distraction. Distraction involves redirection of attention away from the pain and onto something else. It is a simple but powerful strategy to relieve pain. Distraction involves engaging the patient in any activity that can hold his or her attention, e.g. watching TV or a movie, conversing, listening to music. It is important to match the activity with the patient's energy level and ability to concentrate. Hypnosis. Hypnotherapy is a structured technique that enables a patient to achieve a state of heightened awareness and focused concentration that can be used to alter the patient's pain perception. Hypnosis should be delivered and monitored only by specially trained clinicians. Relaxation strategies. Relaxation strategies reduce stress, decrease acute anxiety, distract from pain, ease muscle tension, combat fatigue, promote sleep, and enhance the effectiveness of other pain relief measures. Relaxation strategies include relaxation breathing, music, imagery, meditation, muscle relaxation, and art. See Chapter 6. Nursing and interprofessional management. Pain. You are an important member of the interprofessional pain management team. You provide input into the assessment and reassessment of pain. You help in planning and implementing treatments, including teaching, advocacy, and support of the patient, caregiver, and family. Because patients in any care settings can have pain, you must be knowledgeable about current therapies and flexible in trying new approaches to pain management. Together with the patient, develop a written agreement or treatment plan that describes the pain management. The plan should ensure that pain will be treated based on the patient's perception and report of pain. When appropriate, the plan outlines the gradual tapering of the analgesic dose with eventual substitution of parenteral analgesics with long-acting oral preparations and possibly cessation of opioids. Many nursing roles are described earlier in this chapter, including assessing pain, giving treatment, monitoring for side effects, and teaching patients and caregivers. However, the success of these actions depends on your ability to establish a trusting relationship with the patient and caregiver to address their concerns about pain and its treatment. Effective communication. Because pain is a subjective experience, patients need to feel confident that their reporting of pain will be believed and will not be perceived as complaining. The patient and caregiver need to know that you consider the pain significant and understand that pain may profoundly disrupt a person's life. Communicate concern and commit to helping the patient obtain pain relief and cope with any unrelieved pain. Support the patient and caregiver through the period of trial and error that may be necessary to implement an effective therapeutic plan. It is important to clarify responsibilities in pain relief. Help the patient understand the role of the interprofessional team members as well as the patient's roles and expectations. In addition to addressing specific aspects of pain assessment and treatment, evaluate the impact that the pain has on the lives of the patient and caregiver. Table 8.15 addresses teaching needs of patients and caregivers related to pain management. Challenges to effective pain management. Common challenges to effective pain management include misunderstandings about tolerance, physical dependence, and addiction. It is important for you to understand and be able to explain these concepts. Table 8.16 lists barriers to pain management and strategies to address them. Tolerance. Tolerance occurs with chronic exposure to a variety of drugs. In the case of opioids, tolerance to analgesia is characterized by the need for an increased opioid dose to maintain the same degree of analgesia. Although the development of tolerance to side effects, except constipation, is more predictable, the incidence of clinically significant analgesic opioid tolerance in chronic pain patients is unknown, since dosage needs may increase as the disease, e.g. cancer, progresses. It is essential to assess for increased analgesic needs in patients on long-term therapy. The interprofessional team must evaluate and rule out other causes of increased analgesic needs, such as disease progression or infection. If significant tolerance to opioids develops and the opioid is losing its effectiveness, or intolerable side effects are associated with escalation of doses, the practice of opioid rotation may be considered. This involves switching from one opioid to another, assuming that the new opioid will be more effective at lower equinalgesic doses. However, very high opioid doses can result in OIH rather than pain relief. This means that increases in the dose can lead to higher pain levels. OIH discussed on page 115. Physical dependence. Like tolerance, physical dependence is a normal physiologic response to ongoing exposure to drugs. It is manifested by a withdrawal syndrome when the drug is abruptly decreased. Manifestations of opioid withdrawal are listed in Table 8.17. Let's read that. Manifestations of opioid withdrawal syndrome. Early response, 6 to 12 hour. Psychosocial anxiety. Secretions, lacrimation, rhinorrhea, diaphoresis. Other, yawning, piloerection, shaking, chills, dilated pupils, anorexia, tremor. Late response, 48 to 72 hour. Psychosocial, excitation. Secretions, diarrhea. Other, restlessness, fever, nausea and vomiting, abdominal cramping, pain, hypertension, tachycardia, and insomnia. When opioids are no longer needed to provide pain relief, a tapering schedule should be used in conjunction with careful monitoring. A typical tapering schedule may involve reducing the dose by 20% to 50% per day. The goal is to reduce the amount of medication and at the same time minimize adverse and withdrawal effects. Pseudo-Addiction. Inadequate treatment of pain can lead to a phenomenon called pseudo-addiction. This occurs when patients show behaviors associated with addiction, e.g. frequent requests for analgesic refills or higher dosages, but the behavior resolve with adequate treatment of the patient's pain. These patients are often labeled as drug-seeking, which can result in mistrust between the patient and HCP. This problem can be avoided by effective communication strategies and optimal pain management. Addiction. Addiction is a complex neurobiologic condition characterized by aberrant behaviors arising from a drive to obtain and take substances for reasons other than the prescribed therapeutic value. See Chapter 10. Tolerance and physical dependence are not indicators of addiction. Rather, they are normal physiological responses to chronic exposure to certain drugs, including opioids. Addiction rarely occurs in patients who receive opioids for pain control. If addiction is suspected, it must be investigated and appropriately diagnosed. It should not be implied without evidence because this interferes with pain management. The hallmarks of addiction include 1. Compulsive use, 2. Loss of control of use, and 3. Continued use despite risk of harm. Risk monitoring. Several opioid risk assessments are available to help clinicians assist patients for abuse, misuse, and addiction. A controlled substance agreement for those at risk for addiction may be used. Addiction risk assessment tools, such as Opioid Risk Tool and the Screener and Opioid Assessment for Patient Pain, are available. Patient monitoring with urine drug screens and access to state prescription monitoring programs to track prescriptions are effective in detecting misuse of drugs. The risk for addiction should not prevent HCPs from using opioids to effectively treat moderate to severe acute and chronic pain. Institutionalizing pain education and management. Besides patient and caregiver barriers, other barriers to effective and safe pain management include inadequate HCP education and lack of institutional support. Traditionally, medical and nursing school curricula have spent little time teaching future physicians and nurses about pain and symptom management. The lack of emphasis on pain has contributed to inadequate training of HCPs. We have made progress overcoming those barriers. Medical and nursing schools devote more time to addressing pain. Numerous professional organizations have published evidence-based guidelines for assessing and managing pain in many patient populations and clinical settings. Institutional commitment and practices are changing clinical practice. One major step in institutionalizing pain management is the development and adoption of the Joint Commission TJC guideline on pain. TJC is the accrediting body for most healthcare facilities, hospitals, nursing homes, and healthcare clinics. Under these standards, healthcare facilities are required to 1. Recognize a patient's right to appropriate assessment and management of pain, 2. Identify pain in patients during their initial assessment as needed during ongoing periodic reassessments, 3. Teach HCPs about pain assessment and management and ensure competency, and 4. Teach patients and their families about pain management. Ethical issues in pain management. Fear of hastening death by giving analgesics. Common concern of healthcare professionals and caregivers is that giving a sufficient amount of drug to relieve pain will hasten or precipitate death of a terminally ill person. However, there is no scientific evidence that opioids can hasten death, even among patients at the very end of life. Moreover, you have a moral obligation to provide comfort and pain relief at the end of life. Even if there is a concern about the possibility of hastening death, the rule of double effect provides ethical justification. This rule states that if an unwanted consequence, i.e. hastened death, occurs because of an action taken to achieve a moral good, i.e. pain relief, the action is justified if the nurse's intent is to relieve pain and not to hasten death. Request for assisted suicide. Unrelieved pain is one of the reasons that patients make requests for assisted suicide. Aggressive and inadequate pain management may decrease the number of such requests. Assisted suicide is a complex issue that extends beyond pain and pain management. Physician-assisted suicide is legal in some states, e.g. Oregon, Washington. To address the legal and ethical issues about this situation, the International Association for Hospice and Palliative Care prepared a position paper on this topic. Use of placebos in pain assessment and treatment. Placebos are still sometimes used to assess and treat pain. Using a placebo involves deceiving patients by making them think that they are receiving an analgesic when they are receiving an inert substance, such as saline. Many professional organizations condemn the use of placebos to assess and treat pain. Gerontologic considerations. Pain. Persistent pain is a common problem in older adults and is often associated with physical disability and psychosocial problems. The prevalence of chronic pain among community-dwelling older adults exceeds 50%, and among older nursing home patients is around 80%. The most common painful conditions among older adults are musculoskeletal conditions such as osteoarthritis and low back pain. Chronic pain often results in depression, sleep problems, decreased mobility, increased healthcare use, and physical and social role dysfunction. Despite its high prevalence, pain in older adults is often inadequately assessed and treated. Several barriers to pain assessment in the older patient exist. Older adults and their HCPs often believe that pain is a normal, inevitable part of aging and that nothing can be done to relieve the pain. Older adults may not report pain for fear of being a burden or a complainer. They may fear taking opioids. In addition, older patients are more likely to use words such as aching, soreness, or discomfort rather than pain. Be persistent in asking older adults about pain. Carry out the assessment in an unhurried, supportive manner. Another barrier is the increased prevalence of cognitive, sensory, perceptual, and motor problems that interfere with a person's ability to process information and communicate. Examples include dementia and delirium, post-stroke aphasia, and other communication barriers. Hearing and vision deficits may complicate assessment. Therefore, pain assessment tools may have to be adapted for older adults. For example, you may need to use a large print pain intensity scale. Most older adults, even those with mild to moderate cognitive impairment, can use quantitative scales accurately and reliably. In older patients with chronic pain, perform a thorough physical examination and history to identify causes of pain, possible therapies, and potential problems. Assess for depression and functional impairments, because they are also common among older adults with pain. Treatment of pain in older adults is complicated by several factors. First, older adults metabolize drugs more slowly than younger people, and thus are at greater risk for higher blood levels and adverse effects. The adage, start low and go slow, must be applied to analgesic therapy in this age group. Second, the use of NSAIDs in older adults is associated with a high frequency of GI bleeding. Third, older adults often are taking many drugs for one or more chronic conditions. The addition of analgesics can result in dangerous drug interactions and increased side effects. Fourth, cognitive impairment and ataxia can be worsened by analgesics, such as opioids, antidepressants, and anti-seizure drugs. This requires that HCPs titrate drugs slowly and monitor carefully for side effects. Treatment regimens for older adults must include non-drug modalities. Exercise and patient teaching are important non-drug interventions for older adults with chronic pain. Include family and caregivers in the treatment plan. Tables 8.15 and 8.16. Managing pain in special populations. Patients unable to self-report pain. Although the patient's self-report is the gold standard of pain assessment, many illnesses and conditions affect a patient's ability to report pain. These diagnoses and conditions include dementia and delirium. For these people, behavioral and physiologic changes may be the only indicators of pain. You must be astute at recognizing behavioral symptoms of pain. A guide for assessing pain in nonverbal patients is outlined in Table 8.18. Let's take a look at that. Table 8.18, Assessing Pain in Nonverbal Patients. The following assessment techniques are recommended. Obtain a self-report when possible. Never assume a nonverbal person is unable to communicate pain. Blinking, writing, hand gestures, or nodding can be ways to express pain or the absence of pain. Investigate potential causes of pain. Observe patient behaviors that indicate pain, e.g., grimacing, frowning, rubbing a painful area, groaning, restlessness. Obtain surrogate reports of pain from professional and family caregivers. Try to use analgesics and reassess the patient to observe for a decrease in pain-related behaviors. Several scales are available to assess pain-related behaviors in nonverbal patients, particularly those with advanced dementia and the critically ill. Links to several pain assessment tools are available at the City of Hope Pain and Palliative Care Research Center website. Patients with substance use problems. HCPs are often reluctant to give opioids to patients at risk for addiction or those with substance use disorders for fear of promoting or worsening addictions. However, there is no evidence that providing opioid analgesia to these patients in any way worsens their addictive disease. In fact, the stress of unrelieved pain may contribute to relapse in the recovering patient or increased drug use in the patient who is actively abusing drugs. Guidelines for pain management in patients with addictive disease have been established by the American Society for Pain Management Nursing, ASPMN. These guidelines reflect your role in a team approach in which patients with addictive disease and pain have the right to be treated with dignity, respect, and the same quality of pain assessment and management as all other patients. If the patient acknowledges substance use, determine the types and amounts of drugs used. Avoid exposing the patient to the misused drug. Effective Equinalgesic doses of other opioids may be determined if daily drug doses are known. If a history of drug use is unknown, or if the patient does not acknowledge substance use, be suspect when normal doses of analgesics do not resolve the patient's pain. Aggressive behavior patterns and signs of withdrawal may occur. Withdrawal symptoms can worsen pain and lead to drug-seeking behavior or illicit drug use. Toxicology screens may be helpful in determining recently used drugs. Discussing these findings with the patient may help gain the patient's cooperation in pain control. Severe pain should be treated with opioids and at much higher doses than those used with drug-naive patients. The use of a single opioid is preferred. Avoid using a mixed opioid agonist-antagonist, e.g., butorphanol, or a partial agonist, e.g., buprenorphine, because these drugs may precipitate withdrawal symptoms. Non-opioid and adjuvant analgesics are non-drug pain relief measures, may be used as needed. To maintain opioid blood levels and prevent withdrawal symptoms, provide analgesics around the clock. Use supplemental doses to treat breakthrough pain. IV or PCA infusions may be considered for acute pain management. Pain management for people with addiction is challenging and needs an interprofessional team approach. When possible, the team includes pain management and addiction specialists. Team members need to be aware of their own attitudes about people with substance use problems, which may result in undertreatment of pain. And that is it for Chapter 8.